Welcome back to Kookie Podcast International, and let's continue the conversation with Oliver Thompson.
I've written down 2 questions I would like to address with you. The first one is about touch. Just to say, I have the same problem with all the colleagues that are really attached to the models and the mechanisms. And because I have in common with them the fact that I use the hands, yes, if you mute, okay, it's okay. But I really don't have the same beliefs about what I do, but I still do it and I recognize value in what they do. And at the same time, I'm trying to talk with them, guys, keep going, but stop telling bullshit. The analogy I have is about sometimes sportsmen, people who do sports as a professional. It's no judgment. I am a big fan of sport, but we have some very good examples in French football, for example. He's so good with the ball, and there's this form of intelligence, let's call it intelligence, just to be able to do a rapid synthesis of all these inputs and have the right answer, which is very calibrated. This is really a know-how, something that he learned. And then you hold a microphone to them and they start talking and you say, no, okay, stop talking. Just play. You play very well. And I have the same problem with osteopath. I think that for some, they do a fantastic job. They have a know-how with their hands and they learned. But when you ask them why they do it, it's really disappointing. And this is my very problem still today. But I see that one solution to this problem is to say, to put all the effects on the contextual things and regression to the mean and things that resolve by themselves. But still, I think it's quite comfortable because you get rid of the question, okay, is there something going on, something specific? Because I still think it's something specific. And the point is, we go back to the touch, because I also have a problem with when we say I touch the skull, for example. We don't touch the skull, we touch a person's head. We don't touch pericardium, we touch a person's chest. If we go back to before the problem occurred, for example, if we have a sprain, an ankle sprain or a knee sprain with a rupture of a ligament, it's not a touch-related problem. It's not a problem which is due to a touch. Problems due to touch are very problematic, but it's not in another setting. I think that if we are not capable of provoking a sprain of an ankle just by the effect of touch, it means that still we are subject to physical things in the physical world, which brings it to the biological world, which is there. We still need to eat. When you go to the gym, you cannot just go to the gym and have the contextual effects of going to the gym. You have to lift something. You cannot just touch the kettlebells. And so, in the same way, I see that. Only if I don't talk about chronic low back pains and things who don't have any physical substrate, or it doesn't matter anymore. But if we talk about a very specific situation, which is a subgroup of people who went to a physical encounter with physical energy, like when you do skiing or you're gardening or even rugby, and you have a concussion, yes, but before that, your head has absorbed the energy of an impact. Okay, the brain inside doesn't like to be shaken, but at the same time, the head is still there, and it went through a very physical happening. Something happened physically, and I have difficulties to imagine that just by touching, with light touch, we can talk at the same level that has been talked to the head during the impact. I don't know if I'm clear in what I say. And that's why touch, okay, but if you use deep touch, I don't know how to call it, touch that if you could record strains in bones, for example, I don't know if it is useful. We are not at that point. If I just put my hands lightly on the head, I can't record any strain in the bones. It's not possible. It's not plausible. But if I push sufficiently, I'm going to record some kind of strain, deformation in bones. I'm not here to tell that we have to distort skull, but That's what happens when two heads collide during an impact at rugby. It's for a short time. They have to dissipate the energy of an impact just by distorting, and then they find back the exact same shape. But the question is, after that event, do all things go back to what they were before? Or is it possible that some tissues behave differently and they may be stiffer? And we cannot assess if they're still behaving the same way just by light touch, assessing them with light touch. We have to really test them like we do. I go back to the industrial engineering. If you have to test the mechanical behavior of something, you have to put it to the test. So you have to load it. So I think that when we can use our hand gently, even still with the person, but we can load something and to see how it behaves when we load it. And does it behave in the range of normal, or does it behave really in a strange way, which may be profitable to be addressed? I don't know. I've talked about a lot of things without a question at the end. I don't care. It's just my model is Ricky Gervais, who said, I don't care.
I don't care.
What do you have to say about this bio thing? And it doesn't relate to touch. It's impact.
Yeah, I mean, so if we get to the bit where you said, the collision of it, and this is outside of my field or my limited expertise, but I'm just thinking out loud that if we've got two heads that collide or a head that collides with another object and there's deformation of tissues, connected tissues and bone, does that have implications or subsequent implications for the tissues? Do they return to their normal state? And, what does that mean? And can we assess them? And I mean, I don't know. I'm guessing that in some cases, if they don't, like any connective tissue, if it exceeds its kind of material properties, then you get all creep and hysteresis and all those different viscoelastic effects. And I'm sure on a bioengineering sense, there may be some changes. We can measure them. Who knows? Maybe there are populations of those that have had kind of whiplash or concussion type events, and they're walking around with different, the properties of their connective tissues are different than they were prior to impact. I'm assuming we don't have that data. But even if they are, so what? I mean, what are the clinical implications there? I don't know. It's an open question. It may be the case that, Alzheimer's is caused by, I don't know. I don't know what the implications are. But to me, it strikes me that assuming within say parameters, there aren't any clinical implications. In terms of whether or not we can determine these with our hands and putting force in and seeing how the tissue responds, I think when one speaks like that, it does set up a kind of biomechanical experiment where all variables are, you can remove the kind of noise of other tissues and the foam on the couch that you're pushing through and the skin and the hair and the tissues on your hand, and you can then get some perceptual inferent data there. So again, if it is true that actually these are clinically meaningless outcomes, i.e. the tissues being materially different, they don't mean anything, then I don't know why we bother touching those or trying to assess those tissues. Clearly, there are kind of whiplash-related neck issues and hypermobilities and various things that gross on. I think on the scale that we're speaking about, these are gross disruptions to tissues and ligaments around the upper cervical spine, which I don't know the literature, the reliability. I've forgotten some of the reliabilities of the sharp Purser test and some of these other tests that measure atlantoaxial. I forget those tests, but in some corners, standard practice, we're assessing upper cervical instability. But I mean, I guess what I would say is, it might come back to, if we were going to create a hierarchy of most plausible and most what we know to be more valuable, and the stuff at the bottom is uncertain and has pretty sketchy plausibility, we should probably focus on the stuff which we know to be true and have evidence and have value and to be safe, and worry less about the other stuff, I think. I'm not sure if I've answered your non-question.
Exactly. Since it's a non-question, it's difficult to answer to it. No, it's. I'm interested to have your thought, and you gave your thought, which is very open, and I don't have an answer. It's just possibility, but because at the same time, as I understand, it's my problem with touch. It's just to put all the effects to the manuality to the touch. It's like,
I mean, I'm just going to, if we set up a kind of experiment. So a patient comes into your clinic and they've had a concussion, and you put your hands on their head in a kind of cranial type thing, but not doing, and you notice that, there's some palpatory difference there. I sense that, that it feels a bit, I don't know, whatever the qualities are, a bit stiff when I put some pressure in. The threshold to pain it's a bit sensitive, and you kind of notice that the neck is a bit guarded, a bit braced, a bit tense, a bit stiff. I mean, I think they are all within the realms of plausibility. Like, it's perfectly reasonable if you've taken a bash on the head for you, just like if someone's taken with back pain, there are qualities around how they're using their spine, and the bracing and the guarding and the avoidance behaviors, all those things have palpatory cues, right? When we look at someone and they're hinging from their hips and they just refuse to flex or let their spine relax, so that kind of absence of a flexion relaxation phenomenon. And then again, I don't know, someone will wave some evidence here, so it's not true, but my experience is that you can palpate someone's abdomen and back and they feel guarded and tense. And that, that's not a crazy thing to say. And to then say, well, actually, in those that have taken impacts to the head, there are also these physical qualities. They're guarded, or maybe they've torn their various upper cervical ligaments and they're very floppy. And I think that's all. I think we're not speaking particle physics, right? I think this is within what we know how materials work. I think then the consequence, okay, well, if that's true, how does the manual therapy work and how might that help? And then I think, as you said, there's some context there, but also there's some exposure therapy going on. There's some touch-based reassurance. There's there's this kind of sympathetic tone perhaps dropping. I mean, I think there's a bunch of these kind of different this milieu of mechanisms, but I'm not saying I don't think too much about it, but I don't think it's anything magical. I think there's.
No, I don't think anything is magical in it too.
No, I don't think.
That's the difficulty to stand on that position, is that, yes, it's neither one nor the other. I see that you have understood well what I was trying to say. And since it still stands on things that is unproven, so we cannot go further on that way. But in terms of plausibility, I don't think there's any magic in doing something with my hands to provoke, to let happen changes that only demanded to happen, that couldn't happen for I don't know which reason. So if you take, for example, an impact, we are provided with living tissues that are able to deal with impacts, and hopefully we won't have problems every time we lift something, or we don't get injured anytime we have a shock. So my question is, even if it only happens 1 in 10 times, that after the impact, things don't go back to normal by themselves. And I'm really concerned by these people. The other ones, they don't need even to consult anyone. But the other ones may develop troubles. And when they consult with that reason, I find it interesting to see that, with my hands, I'm able to identify he's in a subgroup where when I load his head, for example, it behaves in a very stiff way, which is not usual. And it doesn't come for constipation problems. It comes from neck and head problems. So I think it makes sense to try to change the modifiable factors, or at least do something with my hands so that it may help things to go back to the normal. There's no magic in allowing things that are supposed to happen spontaneously, but were impeded. And so it's in the same way if you see someone just before an acute low back pain episode, he moves in all the ways, gets up from his chair. And if you see him just 2 minutes after the onset of the acute low back pain, it's a different person, and it's very stable as a situation. We know that it's going to improve. Okay, nobody has ever said, oh, it's magical. Just 1 minute ago, it was completely in shape, and now he can't move anymore. He's in pain everywhere, and he's completely torn. And nobody says it's magical. But the problem is that when someone goes to an osteopath or chiropractor and he reverses, he provokes. I don't see it as magical, but it may be impressive that someone with a stable condition, which is hopefully simple and just demanded to go back to its normal state, with a little help with our hands, when it goes back, when it finds back its initial state, it looks as if it was magical. But why do we treat that as magical? It's just completely logical, and we don't know even the mechanisms that are behind it. But if we don't see magical during the onset, we shouldn't see it magical when we go out from that situation, provided that we talk about a very specific case with reversible things that can go back to the normal. So I don't have a problem with magical things, because we can have impressive results in one consultation with that population. And I don't want to give up with that, even if that attitude won't work for all the chronic people and all other complicated situations. But why should I give up with what worked well in the past?
I don't see the problem if you have a patient with neck and head pain or cervicogenic head pain, let's say, and you notice that there are kind of maybe different behavioral or palpable difference in how their neck and the soft tissues around their head feel. I'm not saying that's a reliable way of going about. And again, I don't know the literature here that we can say for sure that these are reliable ways to assess people's neck and head pain. But I mean, I wouldn't be surprised that if someone's got head and neck pain following some trauma, that there's palpable difference around those tissues. Now, and then that's the first thing. So that's fine. And there's changes to the kind of local sensitivity and thresholds around that area. And in intentional touch, aka manual therapy, may be one modality which can help ameliorate whether the material, whether it changes the biomechanics is a different thing. But in terms of the perception, how it feels to that person, that's perfectly plausible, I think. If you're doing it only because it's worked well in the past, and there are other ways to do it, there are other things to do, or other approaches to take which have better evidence or more plausibility, and you're unaware of them, then there's a problem. Well, then there's a problem, because you should what you might do is learn about them and think, actually, this is a better way, I'm going to do this. Or you're aware of them and you're just choosing not to explore them because you just prefer doing what you're doing, and you're ignoring that evidence, that external evidence. Both are problematic, aren't they? But we would, and again, I'm pretty promiscuous in terms of approaches, that if it was the case that suddenly the evidence showed that manual therapy was clearly more effective than self-management and reassurance and whatever, and we should all, it was on guidelines and there was a kind of consensus in the literature that this, actually manual therapy is really quite effective, I'll do manual therapy. I'm really not bothered what I do. I do put the person or the patient at the forefront. It's not to say others aren't, but I'm just like, what's going to help this person the most, given what we know? I'll just do that. And that's really how the profession should be, right? But with osteopathy, it's a challenge because, and we said this in the paper, that it put all its eggs in the anatomical basket, that A.T. Still was dissecting animals and thought anatomy was a really essential part of health and disease. And it turns out that it's not as simple as that, osteopaths tend not to deal with health and disease. We tend to deal with pain, right? Really, by and large, people's experience and their sense of suffering, and that's difficult. There isn't like you said, there isn't an obvious biological substrate or objective biological kind of entity. And so anatomy has questionable value. And because our intervention is based on the anatomy, because our manual therapy interacts with the anatomy, if the anatomy is mildly redundant, it does make the manual therapy redundant, at least in those original terms, those original explanations. And so that's the challenge. And the identity is around, the identity. And there's this weird linkage, isn't there, that the knowledge was anatomical, the intervention rests on the anatomy, and then the identity rests on the intervention. And once you kind of remove the epistemology, those assumptions around knowledge, it does cascade a bit, doesn't it?
But at the same time, my feeling is that sometimes people tend to say, in the anatomical basket, there are no eggs at all. So don't spend any time. That's if I ever, yes, Hilary Abbey, I know
she's a colleague of mine. Yeah.
Yes, I cannot talk from her place, but she inspired me with her thinking, that she said, among all the things we did, there are things we were good at, with wrong explanations. Okay, but we're good at, and realize that it cannot apply to all the clinical situations. And we have to widen up, to open up to all the knowledge available about how to accompany people who are in pain and things like this. Okay, but do we have to shift and to leave aside everything we did? That's how I live my practice. For example, I began from trying to solve everything with my hands and sweating doing it. Since I tried it, and I tried it hard, I've been able to identify all the situations where it was completely useless. But still, there are situations where it was very useful. And during the time, I tried to identify to which group does this problem or trouble or patient belong? Is it something that is reversible with a mechanical factor that may be addressed and may be changed with my hands, and I will try and sweating, trying to do things? Or is it completely useless? I won't even try, as you said. But still, even if I have someone with low back pain for 20 years, I won't try to change things with my hands. I would talk a lot with them. So it brings us back to the position as a clinician. If we are an educator or I can't remember the
communicator or a treater.
Yes. Now that I have learned to treat chronic people, I don't think it's useful to treat also the acute people without any catastrophizing thought, to treat them in the same way as the chronic people. I think why should I shift my practice? I prefer seeing I will extend my practice and do some triage. Why should I leave the things where obviously my experience, and you can say, okay, it's your experience, but my experience has taught me that it works fine. I've worked for 20 years in the same place, and if really I had killed people, I would have known eventually. And I continue because it's really something it's not hard to do. I can still do, but I still do some education. What do you think about extending our practice? Doesn't mean we have to lose everything. We have to do some sorting. Or should we switch to something else, saying that it was bullshit?
I think there's a mixture. I think there'll be some, for good or for bad, or for better for worse, hands-on manual therapy, touch, whatever you want to call it, seems to be part of the osteopathy lexicon, right? It's part of the identity, practice, expertise, whether anyone likes it or not. I cannot imagine that it will ever just be removed or exorcised in any way. So the fact we've got it, whether we like it or not, there seems to me to be sensible and plausible way to utilize manual therapy, and then nonsensical and implausible way and ultimately unhelpful ways to use manual therapy. What Hilary was saying is that, we can reimagine manual therapy. The psychomotor skills are the psychomotor skills, right? But their application, their reasoning, the judgment of how, whether or not they're used, that can all be improved. But I'm also imagining that there are examples of manual therapy where actually there isn't even a good way of reimagining them, and there's no good use of them. They just get rid of them, and I wonder, maybe there aren't, maybe even the extreme example, all manual therapy can be framed around contextual factors and touch, then actually assuming that it's safe and it's not going to harm the person, then actually you can just replace the kind of weird, stupid mechanism with reassuring touch and context. But I think there are other things. I think there's, even though I said manual therapy is here to stay, I think we can be much more person focused about how we use it. And so if a person comes to see us, rather than presuming that I'm going to give them manual therapy because I'm an osteopath and that's what osteopaths do, whether the person wants it or likes it or not, I think we could just be curious and say, what were you hoping for from today? What were you expecting? What sorts of care do you appreciate? Do you like? What's helped you in the past? Some will say manual therapy. Some will say, actually, I just want to learn more about what's going on and what I can do to support myself. In those cases, resorting to traditional manual therapy because you're an osteopath completely misses that person's values and preferences. The gain there, if you can access their preferences and expectations and trust, essentially, then that to me would be more valuable than demonstrating some identity and say, well, you're going to get manual therapy because manual therapy is really good and I'm an osteopath and I can do this, that, and the other. So I think it doesn't mean we have to get rid of those tools, those manual therapy tools, but how we use them can be different, how we talk about them. The sorts of explanations we offer to patients can change. As you know, us bombarding the patient with garbage, both which are untrue and also unhelpful for them to think about their body in these very mechanistic ways. Not only is the mechanism untrue, but it's also unhelpful because for some patients it will lead to unhelpful conceptions around their own body and their own sense of fragility, adaptability, capacity, etc. So I think we can just talk about them differently. Mm-hmm. And I think that, if anything, that adds therapeutic stock, right? That you're removing the nocibic stuff and actually adding on some more placibic mm-hmm. ideas too. So I think, if I thought manual therapy was utterly if it was zero sum, if that's the right word, had negative value, I wouldn't do it. I think for some patients it does have negative value. I think recognizing that and being grown up enough to think, actually, there are other ways in discussion with the patient, that we can approach this, which doesn't include manual therapy, to feel absolutely confident that's an option, rather than feeling some historical obligation or professional obligation to still do manual therapy. So I think just being open to other ways of practicing and just broadening our therapeutic approach. And it's okay, well, and that's with my own patients, I'll offer them, I say, these are the sorts of things that we can do, or not we can do. I guess we can do. We've got some manual therapy. We can speak about lifestyle. Or there's a range of things. This might be my view, but what's yours? What do you think? How does that sound? And patients might say, I don't know. You're the osteopath. And then you've got to have a conversation. So I appreciate that, and I've got my ideas, but I'm really interested to hear yours. If they still say, I don't know, then you don't push them on it. You respect that, and you might go with their consent, with your approach. But it's involving the person a lot more. It's shifting the expertise away from, I have all the knowledge, I have all the skills, I'm going to assess your body and determine what your body needs. It's involving them a lot more, sharing those decisions. And we can still do all of the same stuff that we were doing, but there's a change in therapeutic stance and positioning.
I think that what you say is undoubtedly a progress in the profession, to go from something very anatomical and anatomically bound to something very person-centered approach. To me, it's definitely a progress, an evolution that is undeniable. And then the question remains open: which place do we give to the manual approach? And so we can be also a little bit fluid about that, with the fact that if we put wrong thoughts about mechanisms in the head of patients, things that are known to be wrong already, I don't know if we call it yellow flags. Jerry cites a study that say that the major part of the wrong thoughts people have about their health has been brought to them by health practitioners.
Yeah,
And so,
that's right. Yeah.
and that's a thing we should be aware of. And that's why.
Yeah, I think we have a public health duty in a way, and
course.
without going on to a lecture with patients, but trying to be sensitive to what extent do they want to be made aware of some of these ideas. And some patients, they don't know, they don't care. But at the same time, if they're holding ideas or beliefs which you judge as a clinician to be untrue or unhelpful, or being a potential obstacle to their recovery or the resolution of their symptoms, then I think you're perfectly positioned to open that conversation and say, I've heard you mention this, or to me it sounds like you're thinking about things like this, and you just have an open discussion with them. This is some of the evidence. How does this sit with you? And this is where manual therapy can be helpful in terms of demonstrating some of or violating some of their beliefs, or confirming movement and reassurance and all those sorts of things. And that's where it becomes in a much more CBT or CFT framework. Personally, for me, that's how I tend to use it. And I'm not someone that's been on the CFT courses, but I've read enough about it and listened to enough podcasts and videos and stuff with Peter Sullivan. I've got a reasonable sense of it. And it seems to me to be far more coherent. It seems to make sense. It seems to integrate the bio, the psycho, the social in a much more cogent way, coherent way than some of the other existing models. So I'm not saying you can't make a case for the other models, but it's just hard work, isn't it? It's very difficult. Whereas here, there seems to be a much more accessible framework to work from.
If we go back to the way you practice, for example, do you have any feedback from patients? I know that patients choose their osteopath because they know that he or she works in that way. I would be interested to have feedback from your standpoint, given the way you practice that you've just described. What do they say that they appreciate and they prefer? Why do they choose?
Yeah, I mean, it's like everyone else. I only see the patients that are happy with my care, right? The ones that hated me don't come back. And I mean, I've certainly, and you know, I've used this example recently that I had those that are interested. I mean, I have a Google review, which is scathing. I mean, it's terrible. Wow. And it's about a patient that's very unhappy and for a bunch of reasons. And I reflect on that. And I think that on that occasion, I probably didn't consider their preferences, their expectations, and I wasn't targeting my reassurance. And I can see, so in answer to your question, in that instance, I can understand how my approach for some patients delivered in the wrong way, not the optimal way, can be perceived as being not the sort of care that they wanted. For. So that was a really helpful, in a weird, strange way, helpful experience. But I guess there's some of the things that patients, you know, again, maybe these are patients that are happy with my care. So I haven't got some God's eye view of my practice, right? But the sorts of things that patients say to me is some patients say, oh, thank goodness, or I feel really reassured and I'm so glad it's nothing serious. And you said I could go play tennis and I feel great, actually. And when you uncouple pain from damage or hurt from harm, when you disaggregate that and say, actually, they're not the same thing, and having a conversation around that, for many patients, that seems to be a really profound difference in thinking. And that, oh, I understand. Okay, I didn't know that before, but now that, and I'm not assuming that it's going to, that change in outlook or attitude is going to carry on. I know that there's patients might resort, they come back the next week and they still talk in very biomechanical terms, but nonetheless, patients seem to be reassured. I think they seem to value being involved. And okay, no, he was, you know, he listened to me and he asked me what I thought. And he asked me the kind of stuff that I wanted to, you know, the kind of care that I wanted. And I've never been asked that before. What I would hope is that, I'm not for a minute saying I'm any brilliant clinician at all, but what I'd hope is that patients would say, oh no, he really was interested in what I thought and, you know, cared for me and was honest and didn't just, you know, make stuff up. So I think that's what, I mean, I'm not saying, this isn't unique to me or anyone else. I'm sure many osteopaths are doing this. But that's, so I think in contrast, what they're not saying about me They're not saying he had wonderful hands or he really knows how to fix the problem. I'm almost certain they're not saying that. And I know that I have patients that come and see me that have been to see many established osteopaths in my area. And that's when it gets, because they want me, I've seen so, and they've got, they've got brilliant hands and they adjusted me back and all those things. I'm pretty sure they're not saying that about me.
Okay.
I hope they're not.
Okay. And last question. What kind of problems would be potentially related to the fact that they would say Oliver has got golden hands? From your standpoint, what do you see as a...
If they come away from the session thinking Oliver's got golden hands and I'm feeling better because he's done something to my body, essentially, he's made a change, it's either going to be untrue but harmless, or it's going to perpetuate an idea that there was something internal to them inside their body and there's a structural belief there, and that with the right expertise and skills, a clinician can go in and change that. And it creates a kind of, it's like, again, I'm a bit more relaxed about this, but a more kind of passive attitude towards care, and they may seek out future care like that. And I've just got to keep going to someone, I have 10 sessions. And with all of that said, I think where my thinking has changed, I also recognize there are some patients that can hold those views and it has very little impact on their lives. They're not seeing physios or chiropractors or osteopaths for 50 sessions a week, that they hold that view and actually it has no consequence to their existence, and that's fine. So I think when I first made the transition, so to speak, to a more kind of biopsychosocial type view, I was probably much more militant and thinking, no, you have to think like this. And I'm a bit more relaxed that patients are, for the most part, sensible and can hold untrue beliefs without a huge impact to their lives.
That's what I think too. Since the population is so diverse in their expectations, in their beliefs, in their worldviews, it's probably a good thing that they can find very diverse type of modalities, still being ethical and without danger for them to follow. But still in that range, which is really normal, it's interesting to have some diversity so that people still find the type of treatment that responds to their expectation. Because if we all work in the same way, it will work only for one specific type of patient. Ali, are you okay for a short break?
This was the second part of our discussion. In the next episode, we'll go deeper into the qualitative research and qualitative methods used by Oliver Thompson and how it helps us understand our own profession in different countries.